G'day, my name's Patrick and I'm in Far North Queensland. I'm doing topic 6, which is the contemporary packaging of a patient with suspected spinal injuries. This is indicated for anyone that you reasonably suspect has an injury to the spinal cord or column, and the purpose of immobilisation is to prevent secondary injury. It's important to note that it's not a benign procedure. Immobilisation will increase your on-scene time and delay delivery of the patient to definitive care. It can result in difficulty in breathing for the patient, difficult airway management. It can conceal injuries and result in the cost burden of unnecessary radiographic testing. In this video, I will quickly go through the equipment that I'm going to use and then look at the setup, and then I'm going to demonstrate the procedure in a patient who is conscious and cooperative. Thanks for watching. QAS has migrated to disposable single-use soft cervical collars. The reason for that is that no device has been shown to completely immobilise the cervical spine. The main benefit for their use is it reminds both the patient and any healthcare professional to take spinal precautions. Soft cervical collars are more comfortable and comfort improves compliance. The indications for their use are simply the suspicion of a cervical spine injury or potential for a cervical spine injury. The contraindications are penetrating neck wounds or a surgical airway, and there's a number of precautions and complications associated with their use, including increased intracranial pressure in head injury patients, impaired ventilation, increased risk of aspiration, discomfort, masking of injuries to neck or occiput, and masking changes in the presentation, for example, tracheal deviation. This is a spine board, originally designed to assist with extrication as a flat, polished surface with handles. However, by default, patients are often left on it during transport. Spine boards are generally used in combination with the following devices. Cervical collars with occipital padding is needed, head side support such as rolled towels or head blocks made specifically for this purpose, and straps to secure the patient on the long spine board and tape to secure the head. Common clinical issues found with spinal boards include pressure sore development, inadequacy of spinal immobilisation, and pain and discomfort. It is advised that no patient should spend more than 30 minutes on a spine board due to the development of discomfort and pressure sores. This is a scoop stretcher, similar purpose to the spine board, however has the advantage of minimal movement of the patient required to get the board secured underneath them and also release them from the board. Arguably, it's also more comfortable than the spine board. This is a vacuum mattress consisting of a sealed, airtight polymer bag enclosing small beads and fitted with one or more valves. After the air is evacuated, pressure locks the beads in place and the mattress becomes rigid. Once a patient is put on the mattress with a scoop, the sides of the mattress are arranged around the patient and the air inside is evacuated, allowing the mattress to conform to the patient and stabilising the injury. The vacuum mattress confers a number of advantages over alternative means, including comfort, being adaptable to all traumas, and the patient is held very securely. Its drawbacks include its relative fragility. If it ruptures, it is useless, its high cost, and the time taken to evacuate the bag compared to other readily available standard spinal precautions such as the board. Okay, other miscellaneous gear which might be of use. A sheet is useful as the patient's skin should not be in direct contact with the vacuum mattress and may assist in extrication from the mattress when we get to hospital. A pillow between the legs may improve stability and also assist in extracting the patient from the mattress. Okay, so firstly this patient needs to have a C-collar fitted. So mate, listen, we're going to fit a cervical collar to your neck, like you stay on the floor. It's very important that you do not move, okay? And I'm just going to hold your head in place while we do that.
Okay, good.
Yep, you're ready. Okay, good. Okay, mate, are you comfortable? Yep, okay, just remember to do not move. Okay, so the setup, the scoop stretcher has been split open and appropriately lengthened for the patient. The patient's been explained what's about to happen and has the appropriate level of analgesia. The vacuum mattress has been placed on the stretcher and a sheet placed over the top of it, and we're pretty much ready to go. Okay, so mate, we're going to lift you up onto the stretcher. You don't need to do anything, just try and keep the neck really still. I'll give you a hand to that. I'm just going to slide the board underneath you. Okay?
Okay.
You ready? Alright.
Good.
up on the stretcher. That's good. Happy?
Yep.
Alright mate, we're going to lift you up onto the stretcher. Alright? I might count on 3. 1, 2, 3. This way. Okay.
Good.
You got it, that end? Yeah.
Yep. Ready to move.
Okay.
And click.
Yeah.
Take it out. Count.
Okay, on 3. 1, 2, 3.
Yep. Alright. Okay, close it off. You happy with that? Doc?
Yeah, close it off.
Close it off.
Let's put the belts from the stretcher on.
Good.
Okay, this patient's now fully immobilised with head blocks to stop his head moving around within the vacuum mattress. He's got the straps from the mattress and the stretcher to hold both items in place. We've got easy access to his vasculature on both sides. Pillow between the legs, that's to stop any lateral movement of his legs and also assist when we eventually extricate him from the mattress at the hospital. That's it. Okay, so that was the immobilisation of a conscious and cooperative patient by 2 paramedics. Obviously, every situation and every patient that you go to will be different. Some things to keep in mind generally are, with conscious patients, immobilisation is not restraint, so they need to be cooperative. Good basic cares, analgesia, sedation is required. In unconscious patients, they will not be able to tell you if something is hurting, and it can be more difficult to determine if the patient is deteriorating or not. So good assessment prior to the procedure and continual reassessment throughout is required. For example, if they have a penetrating injury that you missed, blood could pool up inside the vacuum mattress before you noticed. In intubated patients, ideally during the procedure, manual inline stabilisation is what would be required, and the person assisting the person intubating, rather than wrestle with them, would allow the person intubating to lift the head and just prevent any unnecessary lateral movement. Anyway, thanks very much for watching. I hope it's been useful.